Awesome. So hello, everyone. Hopefully you're trickling in from the previous session. But just to start the introductions, my name is Sarah Eisinga, and I'm the Manager of Patient Programs, Research and Advocacy here at Lymphoma Canada. And thank you for all joining the session today on nutrition for lymphoma and CLL patients. Now, before I introduce today's speaker, I just want to remind the audience that the session is being recorded. The recording will be available after the conference. And at the end of the presentation, hopefully we'll leave a few minutes to answer your questions. So please type your questions at the bottom of your screen in the question and answer box. And now I'd like to introduce and welcome our speaker, Dr. Thomas Jagoe. Dr. Jagoe completed his training in the UK in respiratory and internal medicine, went on to higher research training, including a PhD focused on nutritional depletion and early lung cancer at the University of Newcastle. At Harvard Medical School, Dr. Jagoe undertook postdoctoral training in molecular medicines of muscle wasting. And for the last 15 years, Dr. Jagoe has been the director of the McGill Cancer Nutrition Rehab Program Clinic at the Jewish General Hospital in Montreal. Thank you very much for joining us today. And now you can start sharing your slides and start the presentation.
So thanks to Sarah for that introduction. And as you've heard, I'm based here in Montreal and I'm the director of the McGill Cancer Nutrition Rehab Program. And I'm going to talk to you today about my perspective on nutrition for lymphoma and CLL patients. But I know from experience that it's important that I manage expectations. I've got a particular perspective on this because of the clinical work that we do. And I read just this afternoon some of the intro that had been included in the program, and I realized that I may not answer directly some of the questions about specific foods and things because of the overall perspective that I have. But hopefully, if there's anything that's particularly important to you, you can include it in the questions, and we can try and address it if it's possible. So the clinical team that I work with focuses particularly on cancer cachexia, which is a wasting syndrome associated with weight loss and muscle wasting. And it's often associated with symptoms such as anorexia and fatigue. And it affects many, if not all, cancers, including those such as lymphoma, leukemia. It's also associated with physical weakness and reduced physical functioning. So we find that patients tell us they can't do what they did 2 months ago, 6 months ago, a year ago. And we know from experiments now going back many years, both in animals and less so, but increasingly in humans, that there are some substantial changes in metabolism, which are probably underlying a lot of these changes. Interestingly, though it seems obvious when you show pictures like this, the beginnings of cachexia syndrome can be difficult to detect in some patients. And there are many possible mechanisms. So it's not that there's just one specific process that's going on. It seems there are a number of different processes that could happen in any one patient or person, and that those can vary from person to person and between different cancers. Indeed, the profile of weight loss and wasting that we see varies a lot across different cancers. And increasingly, even though there have been major advances in cancer treatment over the last decade or 2 decades, we are increasingly aware that sometimes cancer treatments can be contributing directly to some of the wasting that we're seeing, despite all the good things that they're doing in terms of combating the cancer. Now, that's all bad enough in terms of how the patient feels and what they have to put up with, and in terms of all the other stresses that are going on. But unfortunately, the fact that patients lose weight and are losing muscle mass is also associated with poorer outcomes. They're at more risk of complications from the treatments themselves, and worse or higher risk of poor outcomes, so are less likely to respond well to the treatments in the first place. Just to give you some background about how we operate, so I'm part of a core team which includes dietitians, physios, and a nurse. We get referrals from our local oncologists and other professionals, but we can take referrals from across the province in Quebec. We assess patients after doing quite an extensive information capture and questionnaire workup with those patients, and then we come up with an intervention plan. And sometimes involve other services, including those in the community, specialists in supportive care if we have particular symptoms that we feel are important that need to be dealt with, and colleagues in dentistry and other specialties. This is just a quick screenshot really from a paper that we published recently, and I'm not trying to highlight that paper specifically, but more to give you a context of the types of range of patients that we see. And so this is out of 100 patients, you can see that about 15% of our patients are the hematological malignancies. Of those, the vast majority are the non-Hodgkin's lymphoma patients, though we do see some with malignant myeloma and CLL as well. And that reflects the overall pattern of nutritional depletion and wasting that we see across different cancers. I've mentioned that there's different profiles in different cancers, and this is some figures from a review that was published 3 or 4 years ago now. So on the left of the picture, you can see some of the cancers that generally don't present with lots of weight loss and wasting when they're first diagnosed, and those include things like prostate cancer and breast cancer. At the other extreme, you have patients with pancreatic cancer or esophageal or gastric cancer, where weight loss is extremely common. So here in pancreatic cancer, it's anything up to 70% of patients have got at least 5% weight loss at presentation, where it's 15% with prostate cancer. And in the middle, you have the hematological cancers, which have been grouped together here, running at just under half, 45% or so, that present with weight loss. It's still a substantial proportion of patients at presentation, but not quite in the same league as some of the other cancers. And that's just the nature of the difference between different cancers. And that's reflected also in the percentage weight loss, which also varies between those different cancers. It's important, I think, and I struggle sometimes to get this across to everybody, that there are multiple different mechanisms that we think are potentially going on. So if this little box in the middle of this picture is the cancer, whether it's your lymphoma, whether it's your lung cancer, whether it's your gastric cancer, there are a number of different ways in which that tumor activity can affect the body. And these different arrows are showing some of the mechanisms that have been identified over the years, both in animal experiments and in humans. So I have to say that because of the difficulty with some of the experiments, a lot of this work has still only been clearly elucidated in animals. So for example, we know that in many cancers, there are the release of different circulating molecules, some of which we know and some of which we still don't know. We know they're there, but we don't know quite what their identity is, or whether it's 2 or 3 molecules which are working together, which is having the effect. But that can lead to changes in loss of fat mass. It can lead to changes in loss of muscle mass. It can lead to changes in metabolism in the important organs such as the liver, which can then lead to overall tissue loss, changes in things that we to do with the endocrine system called insulin resistance, and other changes in metabolism which have been related to glucose. But importantly, and this has become a little bit clearer recently, though it's been a story which has been around for at least 20 years now, some of this signaling from the cancer may actually be going through the central nervous system. So instead of being directly affecting these tissues through direct mechanisms, it may be that the cancer is also sending, in fact, we believe it's true, the cancer is also sending signals directly to the brain. And for instance, that seems to be the source of the signal which switches off that desire to eat and leads to something called anorexia, which is an important component in reducing food intake in patients with cancer cachexia. It's also probably an important component of why people feel fatigue and why there's this sort of general lack of energy. And in terms of mechanisms, this could be running through some signaling pathways that we know well, including things like the adrenergic system, which is the adrenaline system, or through sex hormones, including testosterone. But increasingly, there are now evidence that there's other molecules that are also being active through this axis, including something called GDF15 and 2 or 3 others, which are actively being researched at the moment. Now, all of what I've said so far applies to pretty much all of the cancers that we see in our clinic, including those with lymphoma leukemia. But I think particularly for this audience, it's probably important to highlight that there are also some differences when it comes to the lymphoma leukemia group. One of them, I would say, is the rapidity of the shifts in disease status. So some patients treated with common regimes like R-CHOP have very rapid and fantastic improvements in their disease status with rapid shrinking of node masses and rapid achievement of metabolic control when they do serial PET scans. By contrast, or in the same vein, when there's a relapse, sometimes the tumor, the nodal masses can grow back very quickly as well, and that poses some problems and means that it's sometimes difficult to, or one needs to adjust assessments quite quickly. In addition, even though I've talked about some of the mechanisms being sort of general in terms of things being released into the blood and circulating factors, it's also true in lymphoma and conditions like CLL, where you have, for instance, enlargement of organs like the spleen. So if the spleen was enlarged in this picture here, you'd see it would be enlarged under the left costal margin, and that quite commonly compresses the stomach, which sits in that area. And so it's more of a direct compressive effect, which causes other problems and requires other solutions in terms of what to do. Many patients on cytotoxic chemotherapy, whatever their cancer type, suffer immunosuppression as a result of their treatment. But I think the group, the hematological malignancies, including lymphoma, leukemia, suffer more prolonged immunosuppression because of the nature of the cancer itself. And that raises other issues as well, because the immunosuppression also increases the risk of other chronic disease, particularly chronic infections, which may themselves contribute to weight loss. So we have to sometimes be alert to the risk of other infections, whether it's mycobacterium infections or PCP or other things which may be in the background and again require different approaches or different treatments. And finally, for those of you that may have looked into this already, the concept of systemic inflammation driving nutritional depletion or weight loss is something which has been around for a long time. But when it comes to lymphoma, leukemia, there's a very much closer relationship between those inflammatory pathways and the cancer itself. So we don't use prednisone or dexamethasone, for example, to treat or the JAK-STAT inhibitors to treat a cancer like gastric cancer or lung cancer, but they're very much well established as part of the treatment for some of the hematological malignancies. Excuse me. So that relationship is very much closer, and I think speaks to some differences in the profile of the approaches that might be used. Some years ago, there was a sense that we didn't really need to worry about nutrition anymore, that because of the advances in oncology treatments that have been, frankly, startling in terms of how treatments have expanded and the way that they're much more individualized and focused now. But there was a feeling that we didn't really need to worry about nutrition anymore, and that what we really needed to focus on was getting the right treatment, and that was going to solve all the problems. And this is just an illustration from a paper that came out 7 years ago, which gives the lie to that idea. And this is simply looking at weight and weight loss. So this was a cohort of 8,000 patients. And on top here, we have something called a BMI, which is a measurement of weight corrected for height. So higher BMI is here on the left on the top and lower BMI at bottom. And this is weight loss. So the patients here had no weight loss, and down here they had considerable weight loss. So in this case, 15% or more. And this grid was corrected for cancer type, stage, treatment, and various other known confounders, age, sex, etc. And despite that, it was clear that those patients who had higher weight with less weight loss had better outcomes than those that didn't. And these numbers here are median survival in months. So across this large cohort, those patients with a higher BMI and no weight loss had a median survival of about 21 to 22 months. By contrast, those that lost weight and had a low BMI had a median survival of only 4 months. So despite being treated with the best treatments that were available at the time, there was still a big effect, a big prognostic importance, as we say, of weight and weight change, speaking to the fact that this isn't something which we can ignore. We get a lot more information about nutritional status, and part of the reason for that is because we're doing many more scans than we used to. And we're getting a lot of information, but you may be interested to know that your oncologists are usually extremely interested in looking at these scans and the reports to understand about the cancer stage and progression, but they're not usually interested in, and they don't really get any direct information about what it's telling us about your nutritional status. And myself and colleagues are trying to get some funding for a study to try and help change that situation. But I'm just going to draw your attention, if I can, to this panel at the bottom here. So these are 3 different individuals, and it's a cross-sectional image of their CT scan through the upper part of the abdomen. And what you're looking at here in the red is the muscle mass outlined in red or highlighted in red. So these 3 individuals have all got the same BMI. They've got the same weight, and it's actually quite a good high weight at 29.4. But when we look across these images, this individual has got a good muscle mass, and this patient has got very little muscle mass. And what's become clear over the last several years is that this is very important information, and that those patients, even those patients with preserved weight with less overall weight loss, are not going to do well if they've got progressive loss of muscle mass. So even within the overall nutritional status, we're coming to understand that body composition, meaning the sort of balance between muscle or lean mass and fat mass, is actually an important factor as well. This has been shown in many different types of cancer, and this is just a panel from a recent paper looking at those patients with diffuse large B-cell lymphoma. And the authors from Korea came up with a scoring mechanism which included looking at muscle mass. And here we have progression-free survival, here we have overall survival. And it's simply a binary scoring system. So the patients that had good muscle mass did much better than those that didn't. And just to again orientate you, this is survival. So let's go to overall survival at 5 years. Overall survival was in the region of 20–30% for those with low muscle mass, and in the region of 70% for those with high muscle mass. So again, speaking to this idea that the overall nutritional status, including muscle mass, seem to be giving us important signals about whether people can do well with treatment or not. That brings us to a big question, which I don't have time to go into in detail, which is what are we going to do about it and what's driving this? And again, one of the ideas that had started to take hold over the last 20 years was that, well, we don't really need to worry about nutrition, and we certainly don't need to worry about what people are eating because it's really irrelevant. And there'd been some studies that had suggested that trying to feed people aggressively was really not going to help. So everybody started forgetting about it. That seems to be not true. It's certainly not our experience in our clinic. And this is a study from, again, this last year, a big cohort of patients. I'm not going to go through all the detail here, but what the take-home message was that reduction in how much people were eating was actually probably the most important factor in determining whether they were losing weight or not. So rather than just ignoring it, I think it's time that we look at that and see how we can address it. So how do we do that in the clinic? And this is a very sort of cut down version of what we do. But certainly for the patients that we see, we certainly do work quite hard to try and correct dietary intake. And these are the sort of criteria that we use in terms of gross energy intake. We aim for 25 to 30 kilocalories per kilogram in somebody that's underweight or losing weight that we need to correct. And we aim for 1.3 to 1.5 grams of protein per kilogram per day. And generally speaking, when we achieve that, we have a much higher success rate in terms of stabilizing weight and getting increase. In addition, we aim to address symptoms, and that's not because we just think it's a nice thing to do. It's because we know that pretty much any symptom is going to be impacting that individual's ability to maintain their weight and also to maintain exercise. So having a toothache, neuropathy, headache, anxiety, diarrhea are all things that we are interested in trying to address, because just coping with symptoms is, which sometimes is what we have to do, but not they making an effort to try and address them. It also seems to have an impact on whether we're successful in addressing some of the other impacts of cachexia. Progressive safe exercise is something which is supervised by our physios, and this again is an important component of improving or arresting the muscle wasting fact that we see in many patients. It's also probably there are other drugs which are in the process of coming to market, which we know do have some direct effects in terms of improving muscle mass. They're not yet licensed in North America, but we know that exercise is one thing which does help promote muscle mass and improve function. And of course, our work is much easier, and if the individual has got optimal cancer control, and so getting the best cancer treatment is a key part of addressing cancer cachexia in the context of what we might call holistic or overall care. So if a cancer treatment is actually leading to lots of symptoms, causing lots of fatigue, leading to terrible neuropathy or other problems, then that may not be the best choice. So when I say optimum, I mean the optimum cancer treatment for that individual. And in terms of general advice for patients, we aim for stable normal weight, meaning that if somebody is already obese, we are usually not advising them to lose weight, and I imagine there may be questions about that. In our experience, aiming for stability in terms of overall weight is probably the best strategy. If somebody's grossly underweight, then we're trying to increase it, but we're not usually actively aiming for weight loss. And in addition, this concept of body composition. So when we have somebody who is obese, there is usually a lot to do in terms of focusing on protein intake and exercise that can lead to changes in body outline without necessarily leading to, or body composition without necessarily leading to body loss, weight loss in the first instance. I would encourage patients, and we encourage patients because we provide this in terms of our team, but I think for those of you that don't have access to a team like ours, that I would ask for help from dietitians, and specifically those that are have experience in the oncology domain, because there are one or two specific features about working in this domain which are particularly important when it comes to nutritional advice, but also to ask your oncologist for help with symptoms and for access to other rehab professionals to give advice on exercise. There are some very good patient information leaflets out there, including from Lymphoma Canada, I understand, about food safety, and particularly for the hematological and malignancy patients, these are very important. And our experience is that individuals should be very cautious about adopting very restrictive diet. I know that, well, the information I see out there on the internet includes some stuff which is really good and really well balanced and sensible, and other stuff which is a little bit more or less advisable, particularly when you're going through treatment. And a final plug is that, as I hope I've outlined, there's still a lot to know about nutrition, particularly in relation to nutrition in cancer. And partly because the lymphoma leukemia group sits between those two extremes, I think that there hasn't been as much research with patients patients with lymphoma leukemia as there should have been in this regard. So I would push you to advocate for that as well. Thank you very much.
Awesome. Thank you for your excellent presentation. Hopefully, we're just going to ask one quick patient question. This patient wants to know if you have any recommendations for supplements that are good for cancer blood patients to consider taking during treatment or while in remission. And they specifically would like you to comment if you have an experience on IV vitamin C infusions.
So there are lots of different supplements out there. There are the standard ones, or standard commonly ones that we come across, and names like Ensure and Boost, which we use when we need to, and I have absolutely nothing against them. They're extremely sophisticated in terms of the concentration of protein, energy, and indeed many micronutrients in there. And some patients need them, some patients don't. So we use those sort of general supplements a lot in those patients, particularly, for instance, if it's very difficult to swallow large quantities, people with mucositis, etc. So every single bit that needs to get swallowed has to really pack a punch. Then those options are very good. They're sometimes not that palatable, and there are a few tricks about that. They can be incorporated in other, you can put them in your coffee, you can have them cold, you can make them into little lollipops, and when they're very cold, some of that sort of chemically taste that some people react to is much less than it is otherwise. And spreading them over a day rather than trying to drink the 250 or 238 mils or whatever it is in one shot. With regard to the specific question about IV vitamin C, yeah, we were involved in a study because there was one of my colleagues was actually very, very keen on this and had a history of research in this domain. The high dose IV vitamin C, as far as I know, I haven't seen any severe bad side effects to it. There's theoretically there are some reservations when it comes to certain treatments, but I personally don't believe that that they're valid. But on the other hand, I also haven't seen in the study that we did, and this was in lung cancer patients, the high dose of vitamin C, it didn't really make any difference. So I haven't seen any convincing evidence that it's a general supplement that should be used by everybody. I know that there are case reports of people saying it's a wonderful treatment for their particular case, but it's not something we can recommend.
Awesome. Well, thank you for that comment. Hopefully that answers the patient question. So thank you again for your presentation, and thank you everyone for joining. Please stay tuned for the next session that's starting in a few minutes. Thank you, everyone.
Thank you.